Hello, this is Beth Taylor. I'm a research scientist slash dietitian at Barnes-Jewish Hospital in St. Louis, and I'm speaking to you today on my behalf and those of my fellow authors listed here. Dr. Patel, who is an associate professor of medicine with the Division of Pulmonary and Critical Care Medicine at the Medical College of Wisconsin. Dr. Martindale, who's a professor of surgery with the Department of Surgery at Oregon Health and Science University. Melissa Warren, who is an advanced practice nutrition support dietitian with Oregon Health Science University as well as the Portland VA Health Care Center, and Dr. Stephen McClave, who is a professor of medicine with the Division of Gastroenterology, Hepatology, and Nutrition at the University of Louisville School of Medicine. The goal for today is to review the top 10 key expert opinion recommendations for nutrition support for the critically ill patient with COVID-19 disease. These expert opinion recommendations are based on a combination of three different types of evidence. Indirect evidence that's drawn from the published guidelines, including the 2016 SCCM ASPEN guidelines and the 2019 ASPEN guidelines regarding the nutritional care of the critically ill adult. Direct evidence from the very few limited published trials in patients with COVID-19 disease that may pertain to this topic today. And lastly, from the clinical expertise from those caring for these patients in the field. The recommendations that I present today do not constitute medical or other professional advice and should not be taken as such. These should be used to help guide the professional judgment of healthcare professionals whose judgment is the primary component of quality medical care. The information presented is not a substitute for the exercise of this judgment by the healthcare professional. We know there are circumstances in clinical settings and patient indications that are going to require actions different from those recommended in this presentation or even guidelines. And in those cases, we think it is the judgment of the treating professional which should prevail. This presentation has been reviewed and approved by the Society of Critical Care Medicine and the American Society for Parenteral and Enteral Nutrition. Just in general, when we think about nutrition in the ICU, we need to think of it as an integral component of supportive care in the ICU. We know critical illness exists in phases: the early acute phase, the late acute, and the post-acute phase. During these acute phases, catabolism is revved up, which can lead to several things, including energy deficit, the mobilization of amino acids, predominantly from the muscle, which will lead to a drop in muscle mass, negative nitrogen balance. And then as critical illness is prolonged, we can get gut dysfunction and dysbiosis, which can insinuate that inflammatory response, and downstream we can even lead to an increased organ dysfunction. As I go through the slides today, I want you to keep in mind you need to follow guiding principles relevant to patients with COVID-19 disease. And those include clustering care, meaning all attempts that are possible are made at one time to bundle care to limit exposure of healthcare professionals to the virus. Adhere to the CDC recommendations, again, to minimize exposure. Do what you have to do to preserve use of personal protective equipment, and by all means follow your own hospital's policy and procedures for caring for these patients at this time. The first key recommendation: when we think about estimated needs for these patients, again, it is pretty consistent with what we're doing now for our critically ill patients. At the end of that first week, we hope to get to a goal of 15 to 20 calories per kilogram of the actual body weight, which usually translates to about 70 to 80% of their estimated needs. Now, the thing that's different is we do not suggest using indirect calorimetry as a gold standard to determine these needs, but instead to use a weight-based or other predictive equation to determine the needs. And that reason is because we do not want contamination of the indirect calorimetry apparatus that could then potentially lead to transition of the virus. The protein requirements, again, very similar, 1.2 to 2.0 grams of protein per kilo ideal body weight per day. We do think it's important to keep in mind that many of the patients with severe COVID-19 disease tend to be those with multiple comorbidities or older. And these are the same patients that could have issues with pre-existing malnutrition. So, as such, you need to keep in mind the risk of refeeding syndrome. And as you start to feed these patients slowly, do frequent monitoring of their serum phosphate, magnesium, and potassium levels and replete those as necessary. Key recommendations 2 and 3. We want to initiate early enteral nutrition, which again is not different from our guidelines for other ICU patients. What we mean by early is 24 to 36 hours within ICU admission or within 12 hours of intubation. What has been proven, and it kind of then can be indirect evidence for these patients, is that EN can be safely provided in patients with sepsis and shock if they have no escalating vasopressor requirements or symptoms of gastric ileus. So now we know that we can safely start enteral nutrition in patients with sepsis and shock, and we can maybe use that as indirect evidence for patients with COVID-19 disease because they actually often meet that criteria. We still prefer the use of enteral nutrition over parenteral nutrition, and when giving enteral nutrition, we suggest using the gastric route, and I'll talk about that a little bit more in a few slides. Key recommendations 4 and 5. When starting enteral nutrition in these patients, start with an isotonic high protein formula. There is not good evidence in medical ICU patients in general to use formulas that have additional components like small peptides or MCT oils. And in these patients specifically that may worsen very quickly or have GI issues, to help with tolerance, we suggest starting with isotonic low fiber formulas. As the patient progresses in their ICU care, you may be able then to add fiber back into their formula. If the patient is getting having worsening hemodynamics, meaning that they have escalating vasopressor requirements, their MAP is dropping, or they have rising lactate levels, you would not advance beyond that trophic rate of 10 to 20 an hour. Otherwise, you could go ahead and slowly advance. We do not suggest checking gastric residual volumes. One, we know they're not very reliable, and also that healthcare worker would have to go in that room several times a day and increase their risk of virus transmission. If you have a patient with worsening hemodynamics and you're thinking, I want to check that to see if they have a gastric ileus, then in that case, at least bundle it or cluster it with other care and do it at the same time. Key recommendation number 6. We recommend gastric feeding over post-pyloric feeding because in general, placement of a tube for gastric feeding takes minimal expertise, and often these patients will already have an NG or OG tube placed at time of intubation, and we would suggest using a tube that is already present as opposed to placing an additional feeding tube. Now, to help with tolerance, because some of these patients are presenting with some GI symptoms such as nausea and vomiting, we would suggest when you gastrically feed them that you start with slow continuous feedings and then advance over bolus feeding. In addition to helping with tolerance, there will be less issues with the healthcare provider having to go into the room to provide bolus feeding every 4 hours, so it would limit viral exposure as well. Continuous feeding also may have the benefit of helping with blood glucose control. If possible, if the room allows for it, we would suggest pulling that feeding tube pole out of the room and allowing the nurse to just add formula as needed to the tube feeding bag. If some of you are getting short on tube feeding bags and you don't have continuous bags available, you can use gravity drip bags and just kind of set your gravity drip rate as another option. Key recommendations 7 and 8. even though you've done everything you can to try and help your patient tolerate enteral feed, it may not be working. You can attempt a motility agent to improve their tolerance. If you use metoclopramide, we would suggest that you keep an eye on their QTC interval at the same time. However, if there seems to be a persistent ileus or GI intolerance, signs such as nausea, vomiting, diarrhea, we would say have a low threshold of changing over to parenteral nutrition. The other reason you're going to change earlier to parenteral nutrition is if they have an escalating vasopressor requirement. Remember, these patients are probably going to have more than like a 3-day stay in the ICU, and often many of them get sick quickly. So it's okay to have a low threshold to change over to parenteral nutrition to meet those needs. If you're changing to parenteral nutrition, we do suggest that you use soybean oil limiting techniques, and that may be by using alternative lipids or withholding soybean oil for that first week in the ICU, or only giving it a couple of times during that first week. If you're giving your patients lipids or propofol, which is a soybean oil based drug, we suggest monitoring triglyceride levels. We're hearing from people caring for these patients that many of them are having elevated triglyceride levels, so we would suggest monitoring for that as well. If you have the opportunity, again, with the room set up, that you could pull the IV pulls outside of the room, then your parenteral nutrition bag could hang out there as well, and it allow you access to change that bag as needed without entering the room. Key recommendation number 9, what to do if you're using prone positioning. This is often used in ARDS patients, so we can pull from that indirect evidence that we have in ARDS patients. And we know that these patients can safely be fed enterally. And not only can they safely be fed enterally, they can be safely fed in their stomachs. So what we would recommend is similar to what I've already mentioned. You would start with an isotonic high protein formula at a low rate, feeding gastrically with slow advancement as tolerance is noted. Keep that head of the bed elevated using a reverse Trendelenburg to at least 10 to 25 degrees with gastric feeding to limit that risk of aspiration of contents. If you feel like there is reflux in these patients when you're caring for them, then you would discuss the risk-benefit ratio of placing a post-pyloric tube in the patient versus, again, having a low threshold of transitioning them to parenteral nutrition. However, we would suggest a trial of enteral nutrition first. Then the last recommendation, what to do if they're on ECMO. There had been concern in the past that ECMO patients may have more issues with gastric emptying and would not tolerate gastric feeds or be at a higher risk of bowel ischemia, but that's not necessarily been shown to be the case in the literature. If you look at the most recent study, which is the largest to date in ECMO patients, these patients were able to tolerate enteral nutrition, and when it was compared to delayed enteral nutrition, early feedings showed improvement in 28-day mortality, and there was a 0 incidence of bowel ischemia. So again, we would suggest in these patients to start slow gastric, continuous enteral feeding, advancing over that first week. Again, if these patients get sick quickly and are becoming very shocky with increasing vasopressor requirements, you'd want to hold those enteral feeds at a low rate and then have a low threshold to changing to parenteral nutrition if you're unable to advance those feedings because they are hemodynamically unstable. So in conclusion, I think the delivery of nutritional therapy in this patient follows the same basic principles of critical care nutrition delivery as recommended by societal guidelines to all our patients. The changes that we've made in these recommendations are based on the fact that we want to increase tolerance of enteral feeding if at all possible, and we want to do it in such a manner that we decrease risk of virus exposure to the healthcare professional, and we decrease the risk of contamination of equipment. Because of that, these are the things we suggest that you use an isotonic feeding starting at a low rate continuously to attempt to get those patients to tolerate gastric feedings. In those patients that have gastric intolerance, either due to the disease or to the treatments they're receiving, if there is an individual or professional on the team that could place a post pyloric tube in a very timely fashion without using endoscopy and fluoroscopy, that could be considered. However, it needs to be clear that this is an aerosol producing procedure, and therefore the professional placing that tube would need to wear the proper PPE in order to perform that technique. If you're unable to get post pyloric tubes and cannot make gastric feeding work, then you should have a low threshold of switching over to parenteral nutrition. If you do that, you want to watch triglyceride levels in the beginning, especially if you're using a lipid emulsion with that TPN. In addition, I think overall, whatever you can do to cluster or bundle care is the optimal way to approach these patients. So, as the dietitian, you'll need to be in communication with the other healthcare professionals to see who can do what when they're in that room. We also realize that this is not a time when dietitians will be performing nutrition focused physical exam. That will need to be limited, and you'll have to rely on your other healthcare professionals to give you information regarding things such as their abdominal exam, etc., to determine tolerance. Things are going to be changing quickly, and we realize that. So we are going to suggest that you check back often to the SCCM and ASPEN websites, as specifically on their COVID-19 pages, and see what's new and what's changing not only in nutrition care for these patients, but other care as well. In addition, we know the European Society of Parenteral and Enteral Nutrition will soon be publishing a paper on nutritional care of patients with COVID-19 disease that not only talks about those patients in the ICU, but also those patients in the non-ICU, which we really didn't touch upon in this presentation, so we'll hope that you check that out as well. So I'm going to end there and hope that we've given you some information that you'll find useful, and then I hope that you all stay safe and stay healthy.